I'm going to talk mainly about our care pathway and the impact of changes in tweaks to our care pathway, really, on length of stay. Since April, we've had a consultant in lean thinking, coming and working with us and helping us look at our service. So I'm going to take a little bit of time to just give you an example of some of the work that we've been doing there. We've got 47 medium secure beds. Our primary service is for men, primarily with mental illness. We've got 32 beds in Shrewsbury, which are low secure. We provide prison in reach to 8 local prisons, and I'd say the normal range of community services in terms of court diversion, criminal justice, mental health liaison teams. I'm going to talk a bit more about our forensic liaison schemes in a little while. And just to also put in a plug that we're involved in the pilots for the Community Personality Disorder Partnerships services in partnership with Staffordshire and West Midlands Probation Trust, and also with West Mercia Probation Trust. So basically, I think it'll be very familiar, that's our broad care pathway. People will come in from a range of different services, from prison, from high secure, from local services. Traditionally they would come into our medium secure unit, into the acute wards. They would generally then go through the rehabilitation wards. Some would then go into the community or to other specialist services. Some would go through to the low secure rehab ward that we had, and then out into the community. And then we built an acute low secure ward to enhance the pathway. And the drivers for that, this was about in 2009 that we started planning it. And it was really an opportunity because the low secure service was housed within a large old psychiatric hospital. I think the second last sort of Victorian institution to still be being used. So the trust decided to move to the field next door and build a nice new hospital with low secure services in there, and we used that as an opportunity to build some 12 extra acute low secure beds. But the drivers are about providing a comprehensive pathway, seamless transfer of care, timely access to services, minimising length of stay, and our regional commissioner's objective some years ago was a 5% reduction across the whole of the region, thinking about being really efficient in terms of our assessments, our referrals on, and our discharge. And of course the other drivers were the impact of the Bradley report, really emphasising early identification of service users, of prisoners' mental health needs, the Ministry of Justice's requirement to place prisoners in low secure, not into PICUs, and the 14-day transfer from prisons. So I'm going to whiz through this. You'll be familiar, it was an acute low secure ward, able to take service users that perhaps would previously have had to go into medium secure services, and got slowed down there really by the inevitable additional sort of caution and slowness of services. What I thought you might be interested in was some figures on our length of stay. They come with a big health warning because the acute low secure ward only opened December last year, so we haven't got a year, and obviously it had a graduated opening, so it didn't have all the beds full until the summer, and so of course we haven't got very much data for that, and I'm just trying to do a comparison, so it's rough and ready data. But just to give you that preliminary comparison, over that same period for our medium secure acute wards, acute ward, the length of stay was 267 days. For the intensive care ward, it was 355. I have to provide a second warning, which of course is there are lots of different ways of calculating length of stay, and you can get hugely different figures depending on how you calculate it. So these are figures on completed discharges. These are people who have come into the service and left it. That's what these figures are. So people who needed to go into intensive care, you can see that perhaps that looks like that has extended their stay. their length of stay. If people have gone into through the rehab pathway, their length of stay is just over 22 months, 667 days. The low secure rehab ward, you can see it's very high. That's a spike caused by one service user who had been with us for a long time and was discharged after spending over 2,000 days in secure services. If you took that service user out, the average would be 684. But actually I think that's realistic in that you do have some service users who are with you for a much longer than the average, and that will create spikes in the data. But here's the point: the acute low secure, so far the figure is 204, so it is lower, and you would expect that is because people are coming in, being assessed and going out quicker, back into local services. It has been flux both ways. We've had 2 service users needed to come up to medium secure, but we've also had a service user who was admitted to medium, assessed, and after his court case it was clear that he could go straight down to acute low secure, so it goes both ways. The other figure I thought you might be interested in is the prison to prison, so people who come to us from prison and go back to prison, and the length of stay figure there, as it stands at the moment, rough and ready, is 226 days, which is just under 6 months. That would have been a lot longer a number of years ago. I think what's changed is a real shift in mindset amongst clinicians. We used to have it in our mindset that if people came to us from prison, generally they stayed with us and we would provide them with rehab and they would go into the community from hospital. And so because of the various directives from commissioners, that mindset has shifted a great deal. The other things that have helped us are strengthening the links with our prison in-reach services, so that we have much more confidence, really, that people will be supported when they go back to prison, that there is a lower chance of them relapsing because of the support they will be getting from prison in-reach, and that prison in-reach will be care coordinating and ensuring that there is appropriate follow-up and discharge facilities. Prison in-reach have also helped to speed up our referral process. That's a piece of lean work that we've done on our referral process, but particularly in terms of prison in-reach, they now attend the Secure Services weekly referral meeting, and so they can provide us with up-to-date information. They can say this service user is really deteriorating, we've got to get this referral through very quickly, or they can say, stand down, this person's much better. We realised that we were duplicating, because we can go to the case files of our prison in-reach colleagues who have case files within, they have to duplicate all the case notes from the prison system to the health system. So you can go straight there. You don't have to go into the prison to look at the case files. You can read it through your prison in-reach colleagues. You can have conversations with them who know the service users very, very well. And now we don't need to do the duplicate assessments, either nursing, and often we don't have to do the medical, because often it's our own consultant colleagues who are doing the prison in-reach sessions. So they can speak to each other, and we don't need that duplicate pre-admission assessment, which saves clinicians time and saves time in terms of the service user being accepted and admitted into the service. The other thing that's helped was that emphasis on timescales, having clear target timescales and monitoring and feeding back. A referrals coordinator who has them in mind and is chasing all the time, and the worksheet that goes up on the board every week that says that target's next tomorrow, you missed that target, what are you doing about it? Has really made a difference to how sharp we are in working on these things. But probably the biggest impact on admissions, number of admissions, and on length of stay has been the Wolverhampton Forensic Mental Health Liaison Scheme, which began a long time ago, 1997 it started, and it's developed since then. And basically, you've got a forensic multidisciplinary team who go over to Wolverhampton to one of the CMHT, the Community Mental Health Team bases each week. As it's grown, the scheme now also comprises of a scheme coordinator employed by Wolverhampton Mental Health Trust. There are 3 CPNs from Wolverhampton Trust that come to the meetings. There's a learning disability forensic nurse and a women's worker who also attend. More recently, probation have funded to second a probation officer to attend the weekly meeting. The Afro-Caribbean Cultural Initiative, which is really important and provides a huge range of useful services, culturally appropriate services in Wolverhampton, they send a key worker. And then, of course, there are good links to the courts through the court diversion scheme, through probation. The scheme coordinator goes to MAPA, and there's access to quite a bit of accommodation through ACCI and the local services. And all that happens is that one session a week, forensic team go over there, local teams book in their cases that they want to discuss. It's just been, the scheme has just been described in an article in Advances in Psychiatric Treatment, if you want to know more. So the local team and the forensic team review cases, they provide advice and support with risk assessment and management. And the scheme also tracks every service user from Wolverhampton, mental health service user who is in prison or in secure units anywhere else in the country, and they go to every CPA. So they really have a good knowledge of that service user while they're out of area, and they're able to ensure that smooth transfer back to local services, to community care when they do come back. And the scheme also works closely with the local ICU. What has that meant? Well, it's meant that actually the number of beds required for Wolverhampton patients has reduced by a bit over 2. As the counter incentive again, because that means we get paid less, in terms of service beds, but it's a good thing. And also the length of stay of service users has reduced quite significantly. And really that's about local clinicians having increased confidence in managing service users, rather than saying, we find this too difficult, this has to be dealt with by forensic services. Local clinicians are much more willing to hold these service users, to retain responsibility for them. You don't get all that arguing back and forth. And they're more confident because they know they've got weekly support, they can pick up the phone any time and get support from forensic colleagues. But they're also confident that if there is a problem and the service user needs transfer to secure settings, the receiving team already know them, the Wolverhampton liaison team already know them, and we are committed, we will make sure that we admit. So people are prepared to give things a try in the local area because they're so confident about that. But it works the other way for us as well, because the local teams, knowing that they will get the support, and if there needed to be a recall, it would happen, then they're willing to take service users from us much earlier than we've experienced in other places. So there's a quicker discharge, which also leads to reduced length of stay.